Could everyone take their seats again, please, so we can make a start? Thanks. We're going to start with another brief round of introductions of the panel, because people may not have been present at the first round of introductions. So I'm Andy Mitchell. I'm the Medical Director for the NHS Regional Office for London.
I'm Kaz Fair, and I'm a GP in Camden, sadly north of the river, and a chair of a CCG, a clinical commissioning group, which commissions services from community and some of the hospital-based services.
I'm Chris Strether. I'm the Managing Director of the Academic Health Science Network in South London, which tries to bring together providers of health and social care across the whole population.
Member of Parliament for Greenwich and Woolwich, not a healthcare professional, but know just how important good health is to the community.
Matthew Patrick, a psychiatrist and the Chief Executive of South London and Maudsley Foundation Trust.
And our guests on the panel, Rebecca?
Rebecca Rose, and I'm a GP at Ferryview Health Centre, a member of the Clinical Commissioning Group governing body and the lead GP for our Greenwich Integrated Care.
Simon Hall, I'm Deputy Chief Officer for Greenwich Clinical Commissioning Group, and I've been in the NHS management system for about 26 years.
Helen Smith, I'm Deputy Chief Executive of Oxley's Foundation Trust, and we deliver non-acute, so that's community health, mental health and learning disability services in Bexley, Bromley and Greenwich.
Jay Stickland, I'm the Senior Assistant Director in Adult Social Services in Greenwich, and I manage the social work teams and many of the integrated teams across health and social care.
Thank you.
I'm Debbie Brown. I'm an advanced nurse practitioner in a GP surgery. I also work 8 hours a week in Lewisham Clinical Commissioning Group as the lead nurse for Lewisham Practice Nurses, and I'm also a Queen's nurse.
Hi, my name is Zara Safter. I'm South London Lead for Pharmacy Workforce Development across the whole of South London. I also am Primary Care Project Development Manager for Lambeth CCG.
Hello, I'm Simon Eccles. I'm a consultant in emergency medicine at St Thomas's Hospital.
And Elsa, that was perfect timing. Absolutely perfect. Please, would you like to introduce yourself?
Elsa Pascal. I'm co-founder of a charitable voluntary organisation called Lewisham Ethnic Minority Partnership, and we have a remit in advocating on behalf of BME communities in Lewisham.
Thank you for joining us. And can I just, as in the previous session, if anybody does, I'd like to encourage as much audience participation as possible. So if there's a burning point you'd like to raise or speak about, then please raise your hand and we'll introduce you or include you in the conversation as soon as we possibly can. Now, this session is about integrated care and delivering better care through integration. And I'm very conscious of young people in the audience who may not quite understand what that means. Believe me, you're not alone, because it does mean many things to many people. But in essence, it means ensuring that care is provided in the most, I suppose, integrated or personalised way around the patient. And that means services working in a different way. And that's what we're here to debate today. And as I say, it does mean all sorts of things to all sorts of people, because it means working across different boundaries, it means organisations working together, it means agencies working together, and it's perhaps one of the biggest challenges that we face if we're going to provide cost-effective healthcare. So I'd like to begin the discussion really by turning to yourself, Elsa, if I may. Because in your submission that you made, and thank you for your submission to the Commission, you talked about personalised care, you talked about care that's focused around the patient, just as I've been talking about, and the requirement for primary care and general practitioners to change the way that they work in order to meet those needs. So would you like to sort of give us your perspective, first of all, about the concept and the thinking around personalised care, because that's where integration really needs to happen, would you agree?
One of the examples that I've got, it's about a person who was wheelchair bound and had to move into a disabled bungalow. Now, when she was being assessed for her care, she was told, oh, we can look after this part of you, but this is not our concern. This belongs to the local authority, or this part of it, you have to do it privately. So this whole person was more or less, to me, cut into bits. And one bit of her was to be done by this the health authority. The other bit of her was to be done by the local authority. The other bit of her, she had to do it privately. And there was somebody who was, to me, completely helpless and looking for what I would call looking at the person in a holistic point of view, so that the whole person is assessed, and whatever her needs are, there need to be some joined up working between agencies to cater for her as a whole person.
And was there any single individual who you thought should be responsible for providing that care?
There was no one individual responsible. There was no one department responsible. And the departments didn't talk to each other either. There was no communication, that would care for that person's needs.
Yeah. I'm going to turn to Jay next, actually, because I think what Elsa has very beautifully articulated, really, is the sort of nature of service provision that we offer to a lot of people and young people across the whole health economy. But in Greenwich, you've done quite a lot of work, haven't you, which actually would answer some of the problems and questions that Elsa's raised there. Would you like to give some?
Well, it was exactly those sorts of situations that Elsa's explained that started the whole integration process off in Greenwich. I mean, we recognise that the experience from trying to hop from organisation to organisation, sort of cutting the person up almost into the departments, was very difficult. So we worked very closely initially with our community health colleagues and our PCT at the time, because it was some time ago, in developing a single pathway. So if someone's actually in Greenwich now, rather than the experience your friend had or the person you were working with, there's a single pathway. Now that could be a health or a social care worker, it depends. The teams have mixtures of professions in them, from therapists to social workers to nurses. They go out and see individuals and they treat the whole person. So they'll look at the equipment, they'll look at the person's housing situation, they'll look at the person's health needs, their benefits possibly if they need to apply for things, and actually pull that together for the person.
When you say a single pathway, pathways aren't something that patients actually sort of really fully understand. It's very much a health jargon, isn't it?
At the end of the day, you'll see one person. That's what's really important to the person. You'll see one you'll know have one link person who will pull all those other bits together for you, and you won't have to do the work. It'll be done for you. And I always sort of say it's a bit like a swan swimming along. For the person, it should be just a smooth glide through the system, but actually underneath there's a lot of work going on, but you won't be aware of it. We just pull the bits together, and that's worked really, really successfully for people who have crises. Greenwich now has a rate of about all people travel through our reablement process in Greenwich. It's not a selection process, so everybody who comes in our system is offered that opportunity. And we have about 64% of those people don't require any support at the end of it, and that's about 15% than the London average. So it's really reaping benefits with those people, about pulling all those resources together and delivering it as a single delivery model for those people, and that's proved really successful.
So, Elsa, does that make sense to you?
It does.
But why there are huge barriers, though, to achieving that kind of integration, and we need to explore that and tease that out, don't we? When you set up your system in Greenwich, what were the specific barriers that you had to overcome?
I think that you can go right back to this sort of you've got the biomedical model versus how the professional identities of the people. We come from slightly different directions, so the social care model or the health or the medical model. And what we had to sit down and do was actually sit down with the staff. Once we'd listened to what the patients and what the population were telling us, we had to sit down with the staff and really start unpacking a lot of stereotypes that existed within different professional groups. We had to get people. It was quite surprising to us how little sometimes other professionals knew what we all did. So in other words, was a nurse really clear about what a social worker did? Was a social worker really clear about what a community physio did? So we worked from a basis of getting the staff to coming to a common understanding. And once we did that, we had a really firm foundation. And I think one of the big things in Greenwich that we did, we really majored on engagement with our frontline staff and asked them what were the challenges when they were trying to deliver to Mrs. Jones or Mr. Smith, what was stopping them delivering a really good service. And actually once we got that, they realised they were all trying to work to the same aim. And actually they built the path that, I know we're calling it a game, but it's how we work, but built the way in which they wanted that service delivered. And that's proved to actually give the staff ownership of that model. And once you've got the staff engaged, there is a great correlation between the staff being enthused and actually engaged, and actually the patients or the person actually really receiving a better service.
Now, Debbie, you wanted to come in earlier on, and you've presumably done some pioneering work in Lewisham, haven't you?
Very similar. We're not quite as far as Greenwich, I'm afraid to say, but we're on the right pathway of a single pathway, a single access point. That's the main thing. One phone number. It's manned at the local council, and then you'll see whether it be a physio or a nurse or whoever you need to see at that particular time. But take the step back from that. I feel quite sad that the person that you were talking about didn't have that one person to put them in that direction in the first place, because that, whether you call them a key worker, whether you call them a case manager, whatever name you call them, every person should have one person they can go to that, to me, is like the conductor in an orchestra, that knows a little bit about a lot of different things and knows where to signpost and say, well, actually, I'll give you this number, I can find this number for you, I can send this fax off for you, and start the ball rolling, rather than you being left, or your person you're talking about being left with and not knowing which way to turn. And that's, I think, the important message is for people to know there is somebody out there. It may not be the nurse, it may not be the doctor, it could be a physio, or it could be the receptionist even that you're talking to. So it's where I think general practice plays a really big part, and nurses are integral within that, but it may not always be a nurse that's the case manager.
But Jay, you've alluded to something which is deeply cultural, isn't it? The silo working that we have between professions, with medical profession following the medical model, not necessarily understanding what social workers actually do, what therapists do. So I want to bring in the audience here a bit in terms of the medical students, because I have a sense that we're still perpetuating that. Do you have in your education opportunities to work in a multidisciplinary way? Because this must be a key to integrated working of the future.
I think that's becoming far and far more obvious. Every time we start a new placement, we're always told, go to the MDT meetings, go and sit with the professionals, learn what they sort of do. And now some of us are on a geriatrics placement with care of the elderly. And with them, it's even far more important that they have access to all these services, but it's easy for them to get those things. So it's like they have something called a day hospital, where the patients are transported there and all the people that they need come to them, and the physios, the nurses, the phlebotomists, so they don't have to go to one place and the next place and the next place to gain access to something, because for them they're frail, and sometimes it's really hard for them to get to even one place, and it takes a lot out of them. So I think if anyone wants to add anything else,
Yeah, I think, is that a common experience then, that you're actually having much greater exposure at an earlier stage than to multidisciplinary work?
A lot more now.
I think last year, I think this has come on quite recently as well, we had IPE training, it's interprofessional education training, that was aimed at increasing our knowledge and understanding of the other professionals' roles. I thought that was really important. Right. And it really should be perpetuated.
So we sort of talk to, we have a group session where nurses are there, midwives are there, and we're there, and we have a chance to get to know what they do as part of their role, and how we can help by talking to each other.
Yeah. Okay, thanks.
Andy,
Kaz.
Can I pick up on that, because I think it's a really important issue at the moment, because integrated care is a sort of buzzword at the moment, but it somehow seems to often sit separate from the way in which we will just deliver the totality of services, and that worries me, because there are increasing numbers of patients, and we often talk about the people who are frail and elderly. The patients have got a limited number of long-term conditions as being the people that you manage in this kind of way. This should be what we use as business as usual for the totality of patients whose outcomes are better achieved by looking after them in this kind of way. Yes. And that goes for patients with mental health problems, it goes for children with complex needs, it goes for every patient who has the kind of condition that does not need to go into a hospital. And I think there's a danger that we somehow stick integrated care as something that has to be done by every local authority and every CCG and every hospital as a little bit of work that sits on the side, rather than actually mainstreaming it.
To some extent, I think it's lost its value because of the way it's been used. Yes. Perhaps we could talk about coordinated care, because every patient really requires coordinated care, whether you're a young man who's got a fractured whatever.
Exactly. And it's about integrating care within an organisation as well as between organisations, because many of our patients go into an organisation such as a hospital, and the care that they actually get within that organisation is often not joined up either, let alone when it's actually between organisations.
So the key is really the professional relationships in those circumstances. Question
And
from
the
the
culture.
yes, Kat.
So I agree with there being problems within services as well. I've recently discovered in my area of Essex the child and adolescent mental health services. All 4 tiers are provided by separate providers. And this just seems really odd to me, you know, especially as a patient if you want a seamless journey. And, you know, we know that continuity of care is important. We're dividing our health services up smaller and smaller. And it really worries me that, you know, the privatisation agenda as well because of that.
Okay. Yes, another.
I think it might be something really like that sounds obvious, but because we all have our own sort of individual roles, it's about understanding each other's strengths, but also knowing each other's limits that can, and then working on those together that will help a patient more likely than just doing our own part and then leaving it at that, like working as a whole project.
I'd like to bring my 2 medical guests, actually, not the panel members, into this discussion, because it's, you know, as a medical profession, we've often been that last bastion of sort of individualism to some extent, haven't we, I think, and we've got to change. There's a real challenge to the medical profession to change the way it thinks culturally in relation to other services. So, Rebecca, I knew you've been involved in developing the primary care standards, and a lot of that is about better access to care, holistic care, integration of care. What are your thoughts on about the current integration agenda? You've obviously given a lot of thought to
So
it.
I would come back to what Kaz just says, and in one sense she's just basically delivered our strapline for us, because we are an integrated care pioneer in Greenwich, and we are absolutely adamant that this is not an additional service. This is enabling a multi-professional group across institutions to do business as usual differently. And there's been, I think we talked about institutions and teams working together. One of the things that we're very, very focused on here is individuals working well together. And I think some of the themes that haven't been mentioned, but that we are very strong on here, are trust, flexibility, so understanding roles, but being willing to take them on up to a certain point. Nobody's going to take over an area of expertise, but the flexibility to cover more generic things, so that one person can come into your friend's house and cover quite a lot of roles, and that others will trust them to do that and to work collaboratively. So Jay has been involved over the last 2.5 years in developing integrated teams across health and social care, and our pioneer is about gluing that to general practice and changing the culture of general practice, so that we don't see ourselves as individualists who have to do everything, and we see ourselves as part of this multi-professional team who know each other and share the values with our professional colleagues from other organisations and trust them. And it takes time and a lot of commitment and a lot of hard work to build up those relationships. And that's what our pioneer is about.
And Simon, there is a challenge as well, isn't there, to those of us who work in hospitals predominantly, to actually change the culture of our practice too, to reach out beyond those hospital walls. Would you agree that there's a challenge there?
Oh, I certainly agree there's a challenge, but our model is very much based on members of the public as passive recipients. The people we see are effectively the products of failure of the system, that when bits of it don't work, you end up in A&E. It's the only place that's always open. And I'd like to change that model, because in almost every other aspect of our lives these days, as members of the public, we take control of what happens to us. We don't rely on the state to send us on holiday. We don't rely on the state to buy bicycles for us. We don't rely on the state to do our shopping. We do it for ourselves. And we may choose very actively to take control of that process, and we understand what's possible, what we expect to happen, and we get cross if that doesn't. So how do we get the public to own the care and to own the expectation of successful and coordinated delivery? My son is 3 and was profoundly unwell for the first few years of his life. My wife and I are both doctors. I hope we're moderately intelligent, and I hope we have a reasonable understanding of the way their healthcare system works. That didn't prevent him having 7 different sets of outpatient appointments, 13 different sets of health professionals, and 5 different sets of health records. no two of which could ever manage to coordinate themselves into the same place at the same time in a successful manner. It drove us absolutely bonkers. And if we couldn't navigate through it, what chance does anyone else have for whom the system is a mystery? So how do we change the ownership element? One of the things I think we can do is around healthcare records. And at the moment, some are electronic, particularly in primary care, very satisfactory. But in hospitals, they're in a folder with confidential, do not remove, under any circumstances, stamped all over them. It's surely the patient's record into which we as health professionals add some detail. And if we can move that situation into one in which people feel ownership of every aspect of care provision and understanding of the expectation of delivery, they can take control of it.
So also there's a real challenge there for patients, isn't there? I mean, do you think that the lady you described earlier on would actually like to have to hold that record herself? Do you think that would help her facilitate her healthcare?
Well, without any understanding of what the records say, that's the thing. Half the time you can't read the doctor's writing anyway. So, she wouldn't be able to cope with saying, well, I want this, or I want that, or I want the other. That's why she got me to come and speak on her behalf, to say what her needs are. She can articulate her needs to me, but she would feel maybe mystified to try to articulate her needs to a professional.
That's interesting. But if we helped her, it sort of empowered her to take that on and talked her through what was in the record and gave her options, that would support the whole concept of personalised care, wouldn't it?
Yeah, it would, because then she would have choice.
That's embedded in the emerging primary care standards. The idea of collaborative, joint development of goals between the professional and the service user is one part of the primary care standards.
Simon, can I draw you into this? Because in the CCG, as having a responsibility for strategy, you're going to be sitting there thinking, how am I going to sort of move this unwieldy system forward that's actually so it better meets the needs of patients? What are you doing in your neck of the woods to actually enable that, do you think, to make sure that integrated care is, as we say, business as usual?
Well, I mean, it is, of course, it is the cornerstone of our strategy, and I think one of the things that's worked well in Greenwich is actually all the organisations involved working quite closely together at a particularly difficult time for our local health economy. As you know, we've had a hospital under quite a lot of pressure and some changes, and yet we've got through it. We're not through it all yet, but I think that's one of our biggest challenges in terms of how we ensure that we use actually working in a more integrated and coordinated manner to actually get the hospital to work in a better way, and working very closely with them on that. Things like, and we just heard about patient records, ourselves and Lewisham CCG are working with the Trust to implement the virtual patient record. Now, that's happening, and that will very much support integration, including across Oxley, social care and so on. We also have got some particular challenges in terms of how we move services increasingly into the community, but that's very much part of integration and the agenda we have around that, because actually when you talk to people, real people, not managers and clinicians, they actually want to have their services delivered much closer to where they're living and where they want to access them. So, for example, in Greenwich, we've recently put out phlebotomy services
for much longer
locally.
periods of time. They don't want services that close down at 6 o'clock on a Friday night, do they?
And that is a challenge, but I think there are ways of enabling that. So, for example, at the moment we're just about to put out for a procurement for our urgent care and out-of-hours services, and we're doing them together, so that actually there'll be a 24/7, unlike at the moment when it closes, 24/7 service that will complement the A&E service at the Queen Elizabeth Hospital in Woolwich. So I think we're looking to do that, and through the work we're doing with our general practices, we're looking to see how we can get them to work, and they're very, very enthusiastic about this, together as syndicates on a more geographical basis, so that they may be able over time to actually provide a lot more cover sort of mutually to enable patients to get something much closer to home for a longer period of time. I think one needs to look at whether you need 24/7 services for everything.
You certainly don't, but for some selected services, myocardial heart attacks, strokes, you certainly do, but not for the whole range of services. Cass,
I just wondered if we could bring the audience in, particularly the young people. I just wondered, particularly amongst the young people, if they knew where to go, if there was something the matter with you, where would you go to seek medical care? So if you really weren't feeling very well, or if you've got a relative who has got some kind of long-term condition or serious medical problem, do you know where to go to get medical help?
Yes. GP.
And can you usually get it if you needed to, or your mother needed to take you? Would you be able to get an appointment?
Well, yeah, I remember last time I twisted my ankle, they told me that there was no full appointment. And my mum just kept telling them that this is a child, not an adult. I mean, like, her foot could be seriously broken. And I was just like, there's no appointment. And then if someone cancels the appointment, doesn't come up, then we'll call you or something. Like, my foot really hurt and it was all swollen and everything. It was ugly. So
you went to your GP with that particular problem, did you?
yeah, my mum couldn't take it. It was just so angry, so she took me to A&E and told me that I did twist my ankle, in fact.
So how long did you have to wait to see someone?
Well, they didn't actually call back. The moment they called back was like tomorrow, saying, "Oh, now you can come in." I'm like, there's no point. My daughter's fine.
Went to A&E.
Yes.
Yes.
When I felt ill, I didn't go. I went to the walking centre, but that took quite a long time, like 2 hours. And by the time I went in, I already felt better, so I couldn't tell him what was the matter. So that's all I know. I should go to the GP. I don't know where else to go.
So would you have gone to a pharmacist, for example, or?
No, because I didn't really know what was wrong with me, so I had to wait.
Yeah. Yes, lady behind you there. Yeah.
The trainer, first aid trainer, and I train for Saving London's Lives. And my job is to facilitate the teachers to teach the courses in school. And as a first aid trainer, and I've been for many years, one of the things I spend a lot of time on courses is educating the people on my first aid courses what services to use. Many people in public think that 111 is the emergency number now. So we spend time talking about 999 and 112. Many people don't realise the difference between minor injury units and A&E. They do not recognise that A&E is for emergency services, life-threatening conditions. They wonder why they sit in there for hours and hours with a non-life-threatening condition when they could go to their local minor injuries unit and be in and out within an hour, x-rayed, stitched, glued. And there is a big lack of education, not just with children, but with adults not understanding. Pharmacists are fantastic. You know, we are going to A&E with head lice. It's almost frightening, you know, when we hear about some of the stories that people sitting. So it's back down to education, and we do these big advertising campaigns. You know, we talk about 111, but that takes over. I have adults say that 118 is for the number to call the emergency services. The only person they're going to get is the man with the moustache, because it's not the emergency services. So we tend to focus on, for a very short period of time in Stratford, we had some lovely big yellow models that said about different services to use for different. They weren't there for long enough, and it was in Stratford. You know, why aren't we doing better education? We had the buses. I'm very passionate about this because people do not understand
you're quite right.
Where to go for what they're trying to deal with.
There is total confusion with regards to in the minds of the public.
And
right?
you know, I
Perhaps
train every day, and this isn't just little bit. It's a huge years of this. Not, you know.
So it happens at every single level. So as a GP, the complexity of the system that's round there to support me to look after patients is so difficult to navigate that even though I sit in a clinical commissioning group, I often actually I'm not aware of the totality of the hundreds of services that are there in the community, in the hospital. So it's at every single level, the complexity and the scope of all the different things is very difficult to navigate.
I think you made a very important point about pharmacists, though, and I'd quite like to bring Zara into the conversation here, because although there is the pharmacists have far more numerous patient contacts in the health system than any other group. and there does seem to be a huge potential there for educational opportunities, but also simple clinical health advice. What are your thoughts on that, Zara?
So if I just explain what I'm actually doing at the moment. So what we're doing is recognising that the frontline pharmacy staff is an underutilised resource in the NHS. They are part of the community. They have a little bit more time than the rest of us. And they see people who are not well or people who come in with very minor conditions very often. They don't have the skills to be able to offer an intervention or the knowledge to say this is the referral pathway you necessarily need to take. So what we're doing across through Health Education South London is training all pharmacy frontline staff across all 12 boroughs to become health champions. So what that essentially means is that they have got a public health qualification, and the qualification essentially gives them a little bit more confidence around how to offer brief advice to people. They probably do it on a daily basis anyway, more than likely, but putting that qualification is part of workforce development with pharmacies. What we're trying to essentially establish is that pharmacies are very much part of the primary care world. They're just not recognised like that by the public. The healthy living pharmacy concept is where it all comes from. I actually drove past Blackheath and I noticed the pharmacy's got the big healthy living pharmacy logo on it, which is great. So that pilot's only in Lambeth and Lewisham, which I project managed last year. What it talks about is integration. So why doesn't the local pharmacist go and have a conversation with their local GP? Why is it for things like CalPol? So we've got the minor ailments condition scheme. Why is it for things like CalPol? A GP appointment needs to be taken up. Why is the receptionist staff not had the training to be able to divert that person? And it's really hard to divert a mum whose kid has got a temperature. I've got a 2-year-old. If someone said to me, you know, he's not that ill, go to the pharmacist, it's a skill that you need to have on the telephone to be able to do that. I think what we face, a big issue that we face is cross-border commissioning. So in Lambeth, we do a lot of services through our pharmacy, but if someone walks in through Lewisham, for example, they can't get EHC. So they might be able to get sexual health advice, but the pharmacist has to turn that 16-year-old away because of the complexities of cross-border commissioning. Pharmacists are very, very capable. I think it's very much media-led, and I don't think pharmacists are necessarily portrayed as clinicians, and they are clinicians in their own right. Parts of the country are doing amazing things in terms of the type of services you can commission through pharmacies. There are 100-hour pharmacies which cover areas, and they're local. People can walk to them. You know your pharmacist. And I always said this, I don't ever see my same GP twice anymore, but I have seen my pharmacist there for 15 years, and I know him. I have a relationship with him.
Do you have a sense, though, that you're still working in isolation and not part of an integrated whole?
I feel like it's becoming better. So we're doing a project with NAPC, with the National Association of Primary Care, and it's to do with creating navigators. So the idea is that we will train frontline GP staff with the neighbouring pharmacy staff. So put them both in the same room. They probably don't see each other that often, but it's so that if you as a GP can't signpost in your 7 to 10 minute consultation, you can essentially say you can go down the road and see Linda down the road. She will be able to offer you all the signposting information around this particular subject. And by signposting, I don't necessarily mean healthcare signposting. It's other things that people may need help with in the bigger social
So there's a
care
really
world.
valuable resource here that we should be tapping into to a much greater extent. Matthew, you had a comment there you wanted to pick up.
The fact that as people, we are programmed to form relationships with other people. We're not really hardwired to form relationships with systems. You know, they're kind of mechanical things. And there's something about what you were saying about the pharmacist who you've known for 15 years, or the trust and continuity of the relationship, the single point of contact. People, I think, do well if they know somebody who they can turn to. And if that person is around for a significant period of time, of this continuity. And we have lost that a bit in health and social care with fragmentation. People end up saying they may be highly skilled, but they might never have met them before.
Yeah. So it's encouraging the individual relationships, isn't it, Simon?
One of the reasons people tend to pitch up to A&E is you know that within 4 hours you will be on your way with the problem fixed, irrespective of what the problem is. And so, yes, occasionally we get head lice, but not terribly often. But we do get an awful lot of stuff. Continuity, which we've lost, I think, in some parts of the NHS, is providing the single point of contact who knows all the dimensions around you as well as the healthcare issue. And can we do better that the divisions we've created, primary care, secondary care, social care, healthcare, are replaced in some way with immediate access that something's acutely wrong and you're going to see the first person in the queue and get it fixed now, and continuity, I have a regular condition that requires regular contact and I'll see the same person with whom I'll have a really good relationship. And perhaps we need to tease those.
Which comes back to what your lady would have wanted in the first place, isn't it, really? But those divisions are very artificial constructs. I actually want to think of, well, a challenge. Do you fix every mental health problem that comes your way in A&E? Probably not. You said you fix.
Do we fix it there and then?
No, but you signpost. I do want to focus on mental health. I struggle with this a bit, not my own mental health, I have to say, but in terms of, because it is so all-pervasive, isn't it? It has an impact on every aspect of every patient's life in a way. How can we ensure that mental health services are integrated as part of this greater whole? Because I think there's a real challenge there, isn't there? Helen, do you want to pick that up?
What we've been trying to do in Greenwich, I think, is address these very problems about continuity and also about, which I think you articulated very well, Simon, about helping people take control of their own healthcare, which is fantastically difficult to do. And we heard an example from Earls about how difficult that is for people to do. And certainly phase one of our integration project was putting the structures in place, putting integrated teams in place, putting professionals, clinicians, practitioners in teams together, in rooms together, getting to know how each other worked. But certainly for some of our patients, and the group that we're focusing on particularly at the moment are people with very complex health problems, tend to be older, but actually not exclusively so. For the second phase of our integration project, we sort of honed down on that group to try and see how we can solve this problem. Because these are people whose pathway through services is very complex. So even though we might have integrated teams, individuals themselves need a lot of support. And of course, if you've got multiple health problems, the chances are, and social care problems, you've got actually a very wide range of problems that you need help with. So our second phase is our care navigation scheme, which is a small team. It's working, it's gluing itself to primary care, as Rebecca described earlier, in one bit of our patch in Eltham, working with the 14 practices there. And what it's doing is GPs are referring their most complex patients. And the care navigator is sitting down with the patients and is getting what we're calling I statements. So pulling out of that patient, what do they want? I want this. And then what they're doing, the care navigator is doing, is building a team around that person to deliver the I statements. Now, the GP is a critical part of that, and they're sort of the clinical leadership within the team. But it could be a whole range of different people in the team. It depends on the individual as to who you need in there. So, for example, we were hearing from a GP colleague just a couple of days ago, Rebecca J and myself, a patient who had depression, had a whole load of physical health problems, was frequently turning up to A&E, and actually the GP thought he was the most frequent attender at A&E in the South East, somebody who was turning up 3 or 4 times a week and turning up to the GP surgery. This person was referred to the care navigator, who really sat down and said, what do you want? And actually, he hated his housing and he had damp. He was very, very anxious about the damp in his house, alongside the management of all his other problems. Now, our integrated health and social care teams may not have picked up that more external factor that was very critical to that individual. Focused on that, along, of course, with coordinating all the other inputs that this individual needed. And as of 60 days ago, he's gone 60 days without needing to go to A&E. So that was a good example, we felt, of trying to empower patients to be saying what they want, and then building a team around which can deliver that with a focus on their health and social care. Now, phase 2.5 of that's phase 2. Phase 2.5. At the same time, we're redesigning our mental health services, our older persons' mental health services, and our adult mental health services, so that they can coalesce as well around what we're calling these communities of practice. So hopefully we'll have 4 communities of practice in Greenwich, and we'll have these care navigators pulling in people. We've got our integrated teams there, of community and health and social care already, but our mental health services are right in the process now of redesigning, so they will match onto as well. So they will be divide themselves into communities of practice and glue themselves as well into primary care.
Kaz.
And I thought Debbie and Rebecca might be able to comment.
I'll go first. Okay, so I think the wild card in this is the workforce story, and it's just as true for nursing as it is for GPs. So it is getting harder and harder. Certainly, we are on a constant recruitment in my practice, and it's a huge practice, so we have a high turnover. And so for me, and what lights my professional fire, what I really enjoy, is providing coordinated care for people with complexity. And for me, that means being available to do multidisciplinary work with social care teams, with the community nursing teams. And if I'm working 8 till 8, if the GPs in my practice are working 8 till 8 Monday, 7 days a week, there are going to be far fewer of them to come to our multidisciplinary meetings to have those discussions. So I think we need to be very cautious. Clearly, access is an exceptionally difficult problem that is vexing, loads of people that try to use the service. So I think what we're doing is talking about extending the spread of a limited number of professionals across a very large number of hours. And we should probably be thinking more actively about using technologies and also the kind of teamwork approaches. So the urgent care centres, we have a very good out-of-hours co-op run by local GPs. And that kind of concentration, it's not ideal because you don't get rapid access to somebody who knows you, but you do get rapid access to an opinion from a member of your professional community. And I think we need to tread with caution in how we balance that and be very imaginative in our use of telephone, phone apps, computers, e-consultations. We're just about to pilot e-consultations, etc. And it needs a lot of support. I think that, the other thing to remember, there's a constrained workforce, constrained finances, people are working very hard. Taking on these new ways of working is difficult. It requires a lot of support and enablement, and we can't just say, just go and do it. We have to create this space and the support and the development infrastructure to let people work differently.
And it was quite interesting, wasn't it? Because in the first session, we had a whole row of people who were all going to be doctors. Not a single one of them said they wanted to be a GP, and we haven't asked the medical students who behind them.
Debbie, yes.
Back a step though, actually, from that as well. Not just in Lewisham and Greenwich, but nationally, there's a shortage of practice nurses, and unfortunately, we're an all-ageing population. So what worries me, one is the workforce. Have we got a workforce that's actually there, fit for purpose? But on the workforce that we've got, have we got the training and the support and the new skills that we're going to need to learn? And especially with mental health, that's a missed opportunity that we've got with practice nurses. We're not having the training and support that we need to have. And I felt, very strongly for you at the time, because that was such a missed opportunity. If you was going to visit somebody, whether it be for immunisations, whether you was going to visit for a travel vaccination or a routine check, it's a missed opportunity. That's twofold, sorry.
Martin, yes, please do.
We were talking about earlier. I was at City University yesterday for the launch of their new clinical suites, and the managing director of Health Education North, Central and East London gave a presentation on exactly this. Our medical students are going to be still in hospitals or GP practice in 2060. What will their patients look like then? And are we actually planning a workforce that can meet the changing situation? And they were saying, yes, we are. We are. And more technology was one of the things, actually, that it was important to use that. So I'm fairly hopeful that the new thinking is going to get us somewhere.
But of course, one of the problems is that actually we already have a very significant workforce in the NHS. It's just that most of them are sitting in the wrong place. So the vast majority of the workforces and skills that are needed out in the community are actually sitting in our hospitals.
On the other hand, he did have a slide that said, where have all the hospital nurses gone? And the answer is they're all in practices.
Oh, good.
I think they got lost in the way somewhere.
It's a really important point, though, Kaz, because
we've got a challenge over the next 5 years as well as the next 25 years, and the 5-year challenge is not going to be met through medical education. It's going to be met through working with the existing workforce, who will be the existing workforce predominantly in 5 years' time. So you've got to do both. You've got to have your long sight vision on and think about the future, but we've also got to think about how we support people in working differently in different places with different people now, effectively.
We've certainly talked about rotating staff between hospital and community. We haven't yet cracked it, but it's certainly something we're exploring doing. So.
It's 5 o'clock, and I'm very conscious of not overstaying our welcome with our guests. What I'd like to do is just actually see, first of all, if there are any more comments that the audience would like to make, and then I turn to my panel and my guests here about any quick closing comments they'd like to make as well. So is there any further final questions or comments from members of the audience? Yes.
How we talked about positivity in the last session and integrating that into now, and saying how we can, teach people in the workforce that if they use this service or that service, it can help their people in a positive way. I think that's a good way of looking at
Thank you.
What we can benefit our patients from.
So positive messaging again, common theme. And there was another comment at the back.
I have only learnt today that pharmacies, they actually have more, they actually do more for us, because I only just
more face-to-face contact, absolutely right.
Yeah, because I only just feel like pharmacies where you go to pick up your prescription.
Yes. No, yeah. there's a depth of talent and I suppose expertise that we should be drawing on, actually. I'm sure you'd agree with that, wouldn't you, Sarah? Good. So can I turn to my colleagues? First of all, Chris, you had any concluding comments?
I think sometimes we've got a terrible habit in the health service of doing something right and then not noticing, and the rest of the health service not learning from it. So one of the things we have done quite successfully over the last 20 years, and there are all kinds of problems about the level of investment in mental health, but we have changed an inpatient large institution-based specialty into something that is out in communities and is vertically integrated. And I think there's some of it's actually frankly snobbery from within kind of general hospital care about not learning the positive lessons we can from mental health, about how to change the way we do things and how to use a workforce much more imaginatively. And possibly one of the good things that's come out in the last 5 years is the involvement of mental health trusts in community provision. Oxford's have moved are not now just a mental health trust. So I think we have learnt that patchily, but I think we're not as open to picking up good practice and then applying it to other areas in an area that may not be as intuitive as you are. And so I think there's an opportunity.
Yeah. Thank you, Chris. Kat.
We have to be very cautious with that, because ideologically it's great to move everyone in the community, but that's not okay for all patients. And there was a situation last year where for 2 weeks there were no open mental health beds in the whole country.
Yeah, and I say carefully but quietly.
Yeah.
I think there's an investment. Something about one of the reasons for some of the inequalities in mental health is because of some of the stigmatisation. And one of the consequences of stigmatisation is we don't invest as much in mental health as we did. So I think in some ways it's the level of investment that might be the problem, not the model.
Yeah. Are there any final comments any of my colleagues or the panel members would like to add? Simon.
Very quickly, one point on workforce. I think one of the additional challenges, and I think some of the trusts, particularly Oxleys, are doing a lot to improve that, is if you're in the outer belt around London, which Greenwich just is, it's that much harder in terms of the recruitment drive. So we do see the local hospital and also Oxleys and in primary care, a lot of people who live locally are then sucked in to work at the teaching hospitals, and I think that adds an additional complexity for London that I think we're trying to address through workforce strategies, which we are working on, but it's an additional thing to add, I think, in terms of the debate.
Yes, thanks. And Nick? Oh, sorry, Elsa, yes, certainly.
When a patient gets excellent care, for example, physio in hospital, that needs to be continued when she's discharged, there needs to be a continuation of service, and that patient doesn't have to wait 6 weeks for it to be something needs to be done about this communication between hospitals and community on discharge, so that care is continued.
Yes, because there's a very big divide there still, isn't there? Yeah. And Nick, you had a comment.
Well, I've not said anything in this session because we've had all these excellent witnesses from the area I represent who have been talking about the good work going on to achieve integration, and I'm wholly behind that and very supportive. I really want to just fire 2 warning shots. Integration is not something that is just a goal in the health service. There are a whole series of different areas of public policy or business where you have exactly similar problems of enormous fragmentation and conflict. Just take the process of getting a building built, for example, and trying to get an integrated service from the architect, from the engineer, from the main contractor, from the subcontractors, from the specialist mechanical and electrical engineering contractors, from the facility managers. They're all at each other all the time. It adds cost, and they're often suing each other. So there are problems in other areas, and that goal of trying to get better integrated services is something that I see a lot of in a number of different areas. The 2 big obstacles, as I see it, to getting better integrated services are first the professional silos of individual subject areas and people being reluctant to concede their own profession's monopoly over that particular area. But even more important, I'm afraid, is money. And when there are issues about where resources get allocated, you find people, despite giving lip service to integration, trying to ensure that their part of the service gets the funding. And just as a cautionary tale about pharmacy, I was very shocked a few years ago when, in an area in Greenwich I represent, which is developing, where there's going to be a large amount of new housing and the need for new services, an application by a pharmacist to open a new pharmacy was turned down by the then Primary Care Trust, because it had been objected to by all the other pharmacies in the area who saw it as a competitor. And I had to go and give evidence for 2 hours at a public inquiry, we won in the end, to get agreement that there should be a pharmacy to serve an area of expanding population where there was a need for it. Because actually all the other pharmacists knew financially it wasn't in their interest to have someone else. So I think we've just got to be realistic and recognise there are a lot of financial pressures that are going to be working against the kind of integration we need. And we've got to be realistic about finding answers rather than just talking about the benefits of integration, which I think we all agree. It is not going to be an easy road.
Good. Thank you, Nick. So just some concluding comments from me. First of all, in terms of integration, I think what I've picked up is actually we need to look at this through the eyes of the patient. And I think that came out very strongly from Elsa's first comments. Secondly, I think the strapline that Rebecca picked up, which actually Kaz voiced, was that integrated care needs to be business as usual, and that the real issues here are around relationships and people having the humility to simply step out of their professional silos and communicate and work more, I suppose, coherently across those. And I think if they're the 3 things that we can take away, certainly 3 things I've taken away. Still lots of barriers in terms of workforce and other issues, but some principles there which I think are very important. So I'd just like to conclude by thanking our hosts for the day. It's been a very interesting and informative visit from my point of view, especially with regard to the resus training programme. I'll tick that off as part of my continued professional development. Very helpful for me. Thank you very much for your hospitality. Thank you to the audience, and thank you to my panel guests and colleagues, and hopefully this will have an impact and be registered very highly in the Commission's findings in due course. So thank you all very much, and I guess there may be some more refreshments at the back there, I'm not sure, but even so, thank you all very much, and I won't delay you any longer. Thank you very much.